Could I ask for someone from each of the groups to come to give us a summary? If we could have someone from preclinical, someone from endpoints, and someone from barriers. Hopefully identify yourselves. Maybe we'll just do one at a time. Keep it a little casual. Who's going to come up from our preclinical group? Jeff, who's coming up from your group? Okay. Who's coming from your group? Is it, okay, all right. I know everyone's very excited to go and continue the conversations and socialize, but I'm hoping we could just have 1 or 2 minute summaries from each of the discussion groups, and then we can continue again offline. So we're going to start with our preclinical questions that remain unanswered and how do we address those. I think Jeff's going to kick that off.
Yeah, so I'll try my best to recapitulate what we talked about, but essentially one of the questions that we really focused on that I can sort of remember was the reversal of the haploinsufficiency and whether that leads to a therapeutic margin in patients. And so knowing if you have to act at what age you have to act and how much restoration of SYNGAP expression you need in order to get some sort of therapeutic benefit, that remains a big unanswered preclinical question that basic science can try to answer, especially through animal models. And animal models really are incredibly important for this type of research. And we did talk about that as well as some of the dissimilarity between animal models, some of the rat studies versus the mouse studies, and the peculiarities that you see there. A mouse is not a human, right? And as scientists, we've cured thousands of syndromes in mice. Like, no mice get cancer, right? They just don't. But we can cure them very easily. And we also tried to talk about the cost of potential therapies to patients, in that these gene therapies are in the millions of dollars, not only to develop, and we're talking like not 10 million, we're talking 100 to 150 to 200 million to develop for a company, and then these companies have to recoup their costs in order to make it worthwhile to do that research. And so who pays $3 million for a gene therapy? Is it paid by foundations? Is it paid through philanthropy? Is it paid by insurance companies? And that's another huge consideration. So that's pretty much what our group, we didn't get much further than that, to be honest. So.
Thanks, Jeff. We have our endpoints group. I think Ellie's going to summarize.
I will also try to summarize a lengthy discussion, but I think a lot of what we spent time discussing and going back and forth on is sort of navigating, trying to be very strategic about endpoint selection to maximize the likelihood of success of a clinical trial, but then also making sure that we're remembering to take a step back and allowing the needs of the community and the syndrome as a whole to inform what we measure. So Ingo made a recommendation around thinking through a disease concepts model for SYNGAP to, again, help inform what matters to families and to think about how those might be amenable to an endpoint. We talked a little bit around what already exists in the community, whether that's for SYNGAP specifically or for other DEEs that we might be able to leverage. We went back and forth on this, right? Because I think probably the most practical endpoint would be seizures, but we know that the majority of children with SYNGAP do not necessarily have quote-unquote countable seizures. So does that become a practical endpoint or not? And so, one of the things that we came to a conclusion was that sometimes when you're, again, thinking strategically about trial design or endpoint selection, you don't necessarily need to represent the majority of the community in your endpoint selection. And so while the majority of children may not have countable seizures, does that end up being the most practical strategic endpoint, and would we still consider that? And just taking a look, I think Again, the other thing we kept coming back to was this idea of we know there exists variability within the SYNGAP community. We heard evidence today of some genotype-phenotype correlations, so how do we prioritize endpoints with this variability? And again, we went back to this idea of start with the disease concept model, use that to inform your thinking, but then remember that we can be strategic in the design and that our most practical endpoints may not be those that represent the whole community, but may be what we need to do to get a successful outcome. I think that mostly summarizes it, so probably more questions than answers at this point, but good food for thought and certainly a strong direction coming out with the idea for a disease concept model.
Thanks, Ellie. And I'll just put in a little addendum from my own perspective in terms of thinking about subsequent meetings we might have. I think there's tremendous need to address the potential endpoints that we already know about, but there's also the potential for prevention, right? We have a disorder where there's a long run-up of developmental delay before seizures begin, if and when they begin, and there might be an opportunity to prevent. And I don't know that we would have thought that was possible until our TSC community colleagues have shown that can be done. So I think it's for future meetings, Mike, we should think about talking about not just treating, which is hard enough, but also prevention and keep our goals high. So we're now going to hear from Heather Mestemaker, who's going to summarize the barriers discussion.
So I don't know how I got volunteered for this one, but I'm glad to do it. So our group was really talking about what are some of those key barriers, and I actually fundamentally believe that this group and this audience is doing the right things that we need to be doing. Very specifically, we talked about some of the barriers where it's all about making sure that we're generating awareness, we are developing the reason to believe, and we are working collaboratively. That's ultimately what it boils down to. We talked about the importance of the natural history studies, and we talked about the importance of registry. Why is that important? It's important because we need to understand what is this all disease about? What is the understanding of the patients, what they look like, what do they experience? Because again, we talked about epilepsy is difficult to manage. It's about the whole kid, right? And ultimately our experience as well. So really understanding the experience, ultimately the impact, and then generating awareness through natural history studies registry, but also collaboration and pulling the parents together, sharing the word, right? I mean, this group does amazing work, but continuing to do anything we can do to generate that word. The next part was about connections and collaboration in terms of the science, right? So it's really, we have to build the scientific reason to believe, like why would anyone be interested in this? Why should we do this? So building that repository of information, that data source, which is where funding research is really, really important, and then making sure that we are able to generate connections between those who are in basic to ultimately centers who have lots of patients and people who are going to do the clinical trials. And then we talked a little bit more about specifically the FDA. And, you know, the FDA, they're certainly understanding the regulatory pathways and the challenges, and then thinking creatively. I've had several conversations in the past few hours about how to get people to think differently. But I think what we have as an opportunity in front of us as a patient advocacy group is being able to advocate in front of the FDA. And so we talked about there were some listening sessions, there's an opportunity, and the way we can validate that is by getting our data into places such as the natural history studies so that we can have it published, we can show it, we can talk to it. So it's not just parents talking about it, it's actually got scientific credibility behind it. So I think unless anyone else has something else from our group, I think that's what we got.
Thank you all. I know we don't have a lot of time, but if there's any general comments or discussion, if anyone wants to raise their hand, and if not, and you've had lots of robust discussion and would like to discuss informally, that's also fine. All right, well, I think I'd like to thank again all of you from SRF, everybody who's in front and behind the scenes for the incredible organizational powerhouse that brought us all together. I'd like to thank SRF and the NIH with Vicky's guidance for helping us get through the grant process. And Mike, I think you, it's like, Mike, I think you would like to have the last word, I would hope. Thanks.
Okay, I'm gonna stop. I'm gonna turn this. I'm gonna fade to black. There we go. Thank you all for being here. Thank you, Dr. Pedori and Dr. Sheffer, and I could do all the doctors: Smith, Hicks, Collar, Till. I just want to point out the very unassuming gentleman in the back leaning against the wall is Dr. Daniel Lowenstein, Vice Chancellor of UCSF, who does not know that I called him out this morning and thanked him for his generosity and his accessibility 5 years ago. We were just trying to remember how long it's been. SRF would not exist if it wasn't for Dan Lowenstein. That's actually not true. We can disagree later. But there's a lot I could say right now. And don't worry, I'm not going to say it all. But there are people in this room who we would not be here without. Dan is one of them. Dr. Beduri is one of them. Dr. Sheffer is one of them. Even though she in the beginning might have told me to just give me all her money, give her all my money and just let her do a natural history study. I might not be remembering that exactly right. But it might have happened. There's people like Anna Mignurance, who have also been incredibly generous with their time. And then there's all the families in this room who have worked and given and raised and been generous with time and money. There's Ingo Helbig, and there's Ellie Brimble, who diagnosed my kid. And here's the bad news. In spite of everything we've achieved, it's nothing compared to what we're about to get done. So buckle up, keep going. Our kids are going to get older. This community is going to get bigger. Every one of you who feels like you just got here is going to talk to another 100 families before you're done. Everyone who's raised a few $1,000s is going to raise a lot more. Because we have kids. We are the lucky ones. We're diagnosed. There are thousands of people out there with Syngapians who are not diagnosed. And we need to keep this work up for them and those kids. And we need to be here when they finally get diagnosed, when this ridiculous system of diagnosis we have and all these stupid buses get fixed. And I don't know why I'm going off on this, but I'm just so grateful to Dan, to Anne, to Ingrid, to Ellie. And even though I've been at this for 5 years, it's important to remember there's decades ahead of us. So keep going. Do not stop. Do not even think of stopping. Because we are the lucky ones, because we're here, we know what's wrong with our kids, and we know we can help them. But there's thousands of kids out there whose the parents are still not sleeping, trying random drugs, have no idea what to do next. It's our job to build this house, to make it bigger, to bring them into it, and to help them. That's why we're here. Let's keep it up. Families, we get to come back tomorrow. Scientists, thank you so much for being with us.